لسببين، هي طبعا نشيطه جدا من ناحيه الباثولوجي، لكن هي متمكنه من الانفستيجيشن. فانا متاكد هيبقى في يعني مكسب كبير جدا جاي معانا النهارده، وهنحاول تسمرايز على قد ما نقدر الالجوريثم في الباثولوجي جزء ما هو يعني
خلاص هقول طبعا شويه كتير. اولا انا متعهده بالبلاجر ان انا ابقى موجوده
سعيد الصبح ان انا اصرت تشارك يعني نشكر صاحبك.
الله يخليك. انا بس عايزه قبل ما ابتدي اعرف كم واحد فيكم involved in transplantation ولو involved in follow up even بيشوف post transplantations بيشوفوا post transplantations. اوكي و this is what I care about. يعني انا محاضرتي هتبقى targeted post transplant، فالمفروض ان هي تبقى of interest ان انتوا ممكن تقابلوه، لان basically انا هنتكلم على transplant pathology then I'm talking about what happens in the kidney after being transplanted. وهو عنوان المحاضرة لينا transplant pathology or allographic pathology، بس أنا basically هتكلم على what is specific to transplantation which mainly هيبقى rejection. That's the main topic we are going to cover. لو فضل فيه وقت I also talk very briefly على الكوليوما nephropathy. It depends on the time، بس يعني هيبقى الكلام targeted أكتر على ال rejection. In all cases in allograft dysfunction we need ان احنا يبقى عندنا an accurate evaluation of graft dysfunction and we need to have to know what are the features which will determine a prognosis for that graft, and that's at the end of the day the most important factor we think of. Will it therapeutic implications? So we still have no option except to take renal biopsy. And لو بنقول ان renal biopsy is very important in native kidneys, then you can double or triple the importance in transplant scenario, because this is still the gold standard. And even though it dates at least since 1992, it's still true. It depends على, it changes the diagnosis, it changes the therapy, and most important is the avoidance of unneeded immunosuppression. And you need the biopsy to do this. أنا هبتدي بحكاية. يعني I'm going to discuss the history. وthrough the history أنا هقول the pathology of the transplant, what we started with and what we evolved to دلوقتي, and then I'm going to discuss with you the problems we have and the query entities we still deal with in transplantation pathology. So in order to be able to do this احنا كنا محتاجين بعض standard histological criteria علشان يبقى عندنا end of subjectivity of the histological assessment. يعني simply we need to unify the nomenclature وكلنا to speak one language, and the target is the therapy of the patient. So this was very important. Well, the best way to do this is via classifications. Since they started transplanting, they started to having multiple trials to have proper classifications as old as 76. The main target and a prediction of graft outcome. Yani classifications they were based for the prognosis rather than the diagnosis with the problem of the graft. However, in earlier classifications they did not gain much merit with the society at that. And we cannot be discussing transplant without talking about Banff. I was just asked last week in one of the courses, whenever we say transplant, we say Banff, and I don't know what Banff is. Yani Banff. Yeah, Banff is a small town in Canada. It's a beautiful town, حقيقة, بس هي تقريبا آخر العالم. But it's a small town in Canada, and the first meeting ever, which happened between transplant pathologists, surgeons, and nephrologists, took place in Banff. This was back in 1993, and they came up with the first accepted classification of transplant pathology, Samoa at the time Banff working classification. Banff is a unique classification. It's not a classification which stood at this time. It's a dynamic one. There is a regular meeting every 2 years. In between the meeting, we have internet discussions regarding the issues which needs to be changed. And the last meeting was only last month of August 5th, in a small island in Brazil. I don't even remember its name. And this was last August, and this was the 12th Banff meeting update. It started related to kidney transplantation, but now Banff covers every solid organ transplantation, including liver, pancreas, and even composite tissue. So there is a Banff classification for every organ transplant pathology. What we know, what we still more or less deal with, and what we knew at 1993 with the even began exactly the same, is that we have acute rejection and chronic rejection. And at that time, we had an antibody-mediated rejection, a query entity, and we had a cell-mediated rejection, which we classified, and we had 3 grades of chronic rejection. The latter refers to grades. So 1 is the mildest, and 3 is the severest form of rejection. And in 1993, Banff set a criteria which we still use till now. Number 1 is specimen adequacy. That for an adequate transplant biopsy, we need 2 cores of cortex or at least 2 separate cortical areas. We need 10 glomeruli and preferably more than 2 arteries in order to really evaluate the process. However, we accept a minimum of 7 glomeruli and 1 artery. Less than that, this is an inadequate biopsy. At the time, all what we cared about was cell-mediated rejection, T-cell mediated rejection. So it was defined that the hallmark of T-cell mediated rejection was the presence of tubulitis. I'm going to say what is this in detail. And there was an agreement on the minimal criteria of diagnostics. You need to have more than 25% of the parenchyma of the cortex involved with interstitial infiltration in order to start saying that this is rejection. And you need to have tubulitis, which is inflammation of the tubules. And what is less than this is only suspicion. So it's not enough to have interstitial infiltration. We need both. We need interstitial infiltration and tubulitis. And in order to get into the grades and types of rejection, they came up with a scoring system. And this scoring system covers the 4 compartments of the glomeruli, vessels, tubules, and interstitial. It covers acute and chronic changes as well. And according to what we score, we classify the patient into certain degrees of rejection. So what do we score? We have 4 acute scores. First one is the T score, which refers to tubulitis. Okay, now I check the pointer. Do we have a pointer? I use the mouse. Mouse is not a good idea. Okay, this is not going to solve. This is what we call a DS stain, or pus stain. This is the stain for the basement membranes. It stains the basement membranes this color. You see it? The whole idea is for us to be able to see the basement membrane. It stains the capillary basement membranes of the glomeruli, but it stains as well the tubular basement membrane. So these are tubules, these proximal tubules. This is the tubules, and you can see here glomerulus, and next to it an arteriole. Okay? All these black dots are the lymphocytes, yes, the inflammatory cells. If I just have them in the interstitium, in between the tubules, then this is not rejection. I need these lymphocytes to prove to me that they are aggressive. That they are aggressive lymphocytes. How do I know that they are aggressive lymphocytes? I know they are aggressive lymphocytes when they bridge this basement membrane and lie between the tubular cells. And this is what we call tubulitis. If I don't have tubulitis, then this is not rejection. Okay? So it's not only a matter of interstitial infiltration. So when you come to look at this tubule, these very light ones are the tubular epithelial cells, the very faint ones. Can you see the dark spots? are lymphocytes. Can we count them? 1, 2, 3, 4, 5. So I have 5 lymphocytes within the tubule. When you come to see this tubule, we also have lymphocytes 1, 2, 3, 4, 5, 6, and so on. So we count the lymphocytes because we accept a minimum threshold of tubular inflammation within another body. So we say if I have only up to 4 lymphocytes in 1 or 2 tubules, I will also disregard this. I will not consider it rejection. I need to see more than 4 lymphocytes per tubular cross-section. And I need to see it in more than 1 tubular cross-section. So the threshold for diagnosis of acute rejection is really high. It's not every case that we will diagnose as acute T-cell mediated rejection. So this is the first entity, which is tubulitis. This is what we score. The second thing is what happens within the vessels. Yes. Okay. This is an artery. Again, this is a PS thing. Because with it we see the endothelium nicely. You see this line? This is the endothelium. Okay. So this is our wall and this is the artery. Can you see the lymphocytes? Okay. Again, if I just have lymphocytes like here, see this is a very nice lymphocyte and an endothelium. And the lymphocyte is over the endothelium. This is not rejection. This is not inflammation. Because this is a blood vessel. It's accepted to see inflammatory cells within it. This means nothing. Okay? It has to be below the endothelium. Again, aggressive lymphocytes to call this rejection, to score it within a rejection category, and we call this lesion either transplant endarteritis or entemal arthritis because the lymphocytes are between the endothelium and the antennal. So this is what we call, this is the same region we talk about in vasculitis. This is simply inflammation of the arteries. Then we have the score of the interstitial infiltration, and we score the interstitial inflammation according to the percentage of the core affected. We start from 10 to 25, and this is not within the rejection category. Then above 25%, this is also rejection. The last score is what we call glomerularities. Again, this is a PST. You see the capillary basement membrane. This is quite a high power of the glomerulus. So in order to orient, this is the bone capsule. These are tubules, okay, and this is the glomerulus, and these are the capillary loops. These red lines are the capillary loops. This is the endothelial cell, it's inside. It's inside the capillary loops. But there are other cells also inside in the humerus. If you look here, and specifically if you look here, 1, 2, 3, 4, we have, here it's busy. We have a lot of intraluminal cells. This is what we call glomerulitis or inflammation of the glomerulus. It's also something we score in acute rejection. With chronic rejection, we score the chronic changes. So if I have tubular atrophy, I score it. These are normal tubules, and these are atrophic tubules. You don't see them because when they get atrophic, we usually don't see them. They get to be very small, and the lining is very limited. Yes. So we score the percentage of the core which is affected by atrophy. Same process for fibrosis. These are normal tubules. This is a trichrome stain. This is the stain we use for seeing fibrosis. So these are tubules normal. This is a scarred area of the kidney. This is interstitial fibrosis or these green areas. We have lymphocytic infiltrate and we have tubular atrophy. You can compare these tubules with these tubules. So this is the I score. Again, just a percentage. 1 to 25, 6, 25, 25 to 50, and more than 50. Then these two scores, and these are very important ones, because these are transplant specific. This is the V score, and this scores the entemal thickening of the blood vessels. Okay, what we call entemal sclerosis. And we score it according to the percentage of the reduction of the lumina of the artery we're seeing. The other score is the changes in the glomerular. And what we score here is the presence of what we call double contours. So again, we score the extent, how many glomeruli are there, and how much of the glomerulus is affected, and we put a chronic score. There are two extra scores, which are not summed. We usually sum all these scores and give a sum at the end, but these ones are not included in the sum score. This is the score for arteriolar hyalinosis, which changed now not AH, it's AAH, alternative AH score. This is an arteriole, and all of this red lump is what we call nodular hyalinosis, which is this homogeneous red nodule is what we call nodular hyalinosis, which could be specific to CNI toxicity. And as you see here, we score what we call mesangial matrix expansion in the glomerulus. This is mesangial matrix expansion. This is the loops. In between the loops, you see only a very small area of mesangium. If the mesangium started to be expanding, you see it this way, like in sclerosis. Basically, this is an evaluation of the extent of sclerosis.
How can we differentiate the artery from the
This is tubule. It's lined by epithelial cells. Okay. These are epithelial cells. No, this is an arteriole, not an artery. It has a muscle wall. You have to see the muscle. You don't see muscle in tubules.
I think if tubules is atrophied.
So what do you think this is? An artery or a tubule? It's an arteriole. This is muscle. This is a muscle layer and the lining is epithelial. This is a tubule. Now, even if it's an atrophic tubule, you are not going to see it like an arteriole.
الدبل كونتور في السلايد اللي قبل
I'll go in it in detail.
It's the same question.
I'll cover all of these entities in detail. Okay, so again, خلينا cover a T-cell mediated rejection, or what you used to know as acute active cellular rejection. We have two types of this type of rejection, or three types. Type 1, which is limited to tubular interstitial. So we use the I score and the T score, and we say we have mild and moderate, which is type 1A, or severe, which is type 1B. Okay? What's going to define what's mild and moderate and what's severe is the tubulitis. If I have T2, then I'm still in 1A. If it's T3, even if the interstitial infiltration is just 25%, this is severe rejection. So it's the degree of the inflammation of the tubules which governs the severity of the tubular interstitial rejection we're having. Okay? Interstitial, it's normal to get eczema and inflammation. We see all types of cells in the interstitial. We get lymphocytes, monocytes, less often eosinophils, but we do see them. Rarely polymorphs, and if you see a lot of polymorphs, then you should consider that this is actually an infection, a form of pyelonephritis, rather than it's a rejection. And we can get a lot of plasma cells. This is a very old entity which is still standing till now. Nobody pays attention to it anymore, but this is an entity which is called plasma cell-rich acute rejection. This is a form of an acute rejection which is dominated by plasma cells. And this type of rejection carries a bad prognosis. These patients have bad prognosis. Type 2 is the one which involves the arteries. The one with the enthemal arthritis, the one with the V score. Again, according to the V score, we classify into 2A and 2B. If it's V1, we are in 2A. If it's V2, we are in 2B. So, again, mild and severe. Where am I going to look? I see mainly it's in the arteries. You can see here, again, this is a trichrome stain. This is a high power. You can see the lymphocytes. And this is the muscle. And these are the tubules. Okay? So this is a high power of it. you can get lymphocytes, and we get as well monocytes infiltration. This is a V2. The difference between V1 and V2 is how many, again, the percentage of the lumina involved. If it's more than 25%, then we are in V2. Or if it's more than one artery. If it's V1, but it's in more than one artery, then this is V2. You can get interstitial hemorrhage as well, and sometimes some tubular interstitial drainage. Then type 3, again type 3 is a vascular type, but type 3 is reserved for the entity when you get fibrinoid necrosis within the artery. This is a special type of necrosis. This is the necrosis, again, you see in severe vasculitis, and I'll show you better pictures. But this is the one which has also V3. V3 is transmural inflammation, meaning that the lymphocytes, we have entemal arteritis, but they crossed the wall to outside. So they involve the whole thickness of the wall of the artery, and this is what we call V3, and this puts the patient automatically into type 3, which is the most severe form of rejection. You see it here more clearly. This is extensive entemal arteritis. This pink stuff is the fibrinoid necrosis, and it's passing the wall. It's involving almost the whole thickness of the wall. This is better. Do you see the muscle? If I told you all of this is the artery, this is the lumen, all of this pink stuff is the fibrinoid necrosis, and all of this is the wall eaten up by lymphocytes. I know it would be a bit difficult to imagine, but I just wanted to show you the fibrinoid necrosis in the trichrome. It's really apparent. It takes this very pink color, where we know that this is fibrinoid necrosis. So this is what we call T-cell. I'm not used to call. This is what we still have till now. Nothing of this classification changed since 1993 till today. This is how we diagnose T-cell mediated rejection, and these are the categories we have. So vascular, what we call vascular rejection, is part of T-cell mediated rejection, and I want you to hold this info now till we discuss it later on. Okay? So we have 3 types of T-cell mediated rejection: type 1, type 2, and type 3. What to do with the cases which has T2, that means tubulitis more than 4 lymphocytes, but have an interstitial inflammation of 10%. This does not fit the criteria to put it into type 1 rejection. So what do we do about these cases? And what do we do about the cases with 50% interstitial inflammation and T1, not T2? What are we going to do about these cases? So they created a category which is more or less a wastebasket called borderline rejection. This term, because when you see it in the report, basically means suspicious for rejection. The findings I have are not enough according to the agreed on criteria for rejection, but it's just suspicious. Again, this is not a normal kidney, meaning, again, translating these words into, this is not enough to treat the patient as if he is in acute rejection. You might need to modulate his immunosuppression. You might need to follow up and have another biopsy in a couple of weeks and see what's going on. Or if there is any clinical change in the patient within that week. So this is what this term means. So if we're not able to say that this is really acute rejection, I don't feel comfortable about this kidney, something is going on, we have no option except to use this term. Liliane Gaber in 2004 studied all their cases. She's a prominent pathologist in the States, and they studied a lot of the cases which were diagnosed as borderline, and we found that most of the cases developed later on acute rejection. However, this is not applicable in each scenario. Sometimes the patients are resolving, and bear this in mind. And most of the time, the regular scenario is that usually patients take shots before the biopsy. And in this case, this is what you're going to see. a borderline rejection if you gave anti-rejection treatment before, or that the patient is rejecting and that's the first stage of it. So the first classification was published in 1994. That was followed by a score which is called CATI score, which if you read any literature on transplantation you'll hear about it, and there are some centers which use it, like Mansoura for example. That's chronic allograft damage score. This score came up a couple of years after the Banff working classification. And because this classification wanted to be the most accepted and widely accepted classification, they included the CATI score within the classification, and in a couple of years they published the updates, the meeting report, which included what was in the CATI score. This was followed a couple of years later again by another trial at allograft transplantation, which started in England in the NIH, which called collaborative control trial for transplantation, and this was a very successful one actually. It was much easier than Banff to use than Banff at that time. So again they collaborated it into Banff, and in 1999 came up a new classification which was called the Banff 1997 working classification, an updated classification. I want you to know that at this time of transplants, all what we cared about is T-cell mediated rejection. Antibody mediated rejection was not really in the story, nobody cared about it. And we had a query entity which is called chronic rejection. We did not know how to identify it well or how to score it properly. So by 1997, they came up with a change, which is that they decided that they are going to stop using the term chronic rejection and use the term CAN, which is chronic allograft nephropathy. How many of you is familiar with this term? How many of you still use this term?
Outmoded term.
It is. I'll tell you why it's an outmoded term. So back in 1997, this is what we thought about. We had antibody-mediated rejection, immediate, which is the hyperacute, and the delayed accelerated acute. We had the T-cell mediated rejection, and we changed the term chronic rejection into chronic sclerosing allograft nephropathy, a fatal mistake. And we have to admit that we have missed concepts since then, which we still live with till now. And the first misconcept I was just saying that acute rejection is a process which was usually considered to be mediated by T-cell, because this was the dark age for antibodies. Nobody understood anything about antibody-mediated rejection, and all what we knew is that it existed in this forms. However, this changed by the discovery of C4D. Yes. And by the discovery of C4D, we recognized that we have acute antibody-mediated rejection or acute humoral rejection, which needs to be categorized and identified. So in 2003, they came up with the antibody-mediated rejection criteria as an addition to the classification. Bear in mind that we still work with this classification. We had an addition on the acute antibody-mediated rejection. So what did we do? In 1997, we have this part. This is how the classification works. The classification works into categories. Okay? What we're supposed to do is classify our patients into these categories and then sub-classify them if the category has tags. So either category 1, which is normal, category 2, which is antibody-mediated, category 3, which is borderline, category 4, which is T-cell mediated, and we still have category 5 and 6, and I'm going to cover it later. But let's focus on category 2. This category changed into this. Became acute active antibody-mediated rejection, C4D positive, with 3 types, 1, 2, and 3. So we had to change this one, and this one changed into acute active T-cell mediated rejection. So this one became the C4D positive one, the antibody mediated rejection, and this is the C4D negative ones, the T-cell mediated rejection, which still contained all the types of rejection. C4D, by the way, was not new. Although we integrated this criteria in 2003, C4D was first described in 1991 by Food Group from Munich. That's their paper. And what is the C4D? C4D provided the missing link we needed to have an evidence of antibodies presence. This is basically the capillary deposition of complement C4D in graft biopsy. So we had a unique immunohistochemical marker of antibody-mediated cell reaction. Now what happens normally? What happens normally is that these are our endothelial cells. They get injured and they start to have antibodies. Then they start to develop a reaction against these antibodies, which will include cytokines and complement factors and so on. But normally, all of this is removed by the blood. This is something which doesn't stay on the surface of the endothelial cells. However, what was the unique thing about the C4 and C3, complement 4 and complement 3, is that they have internal protective diagnostic groups which form stable bonds with the endothelial cells, so they stay on for some time. Their complement degradation factor, which is C4D, is able to make these transient covalent bonds, so give us a stable molecule which we can detect at this time. So this is the whole idea. This is a complement, just a complement degradation factor. But the discovery was that this one is able to stay on a bit for some time. And it stains the peritubular capillaries, the capillaries which is in between the tubules, whether by immunofluorescence or by immunohistochemistry. But this is just a footprint, and you need to remember that, because this is like a shower, like the antibody shower. It comes and goes. What makes the transplant specific is that it lies in the peritubular capillaries, because we can see it, sorry, in the native kidney. It can be associated with a lot of other pathology in the kidney, and as I said, it's not a static marker. This is something you need to know while you're evaluating your transplant patient. The C4D can change from negative to positive and can change from positive to negative, because this can reflect transient antibody activity. However, by 2002, this is the recommendation that routine C4D staining should be performed and incorporated as an adjunctive diagnostic tool. It's not enough to ask to do C4D or to have C4D done on your biopsies if you're doubting that the patient maybe have an antibody-mediated rejection. This does not work. C4D is part of the routine transplant work, of the transplant biopsy work. Any transplant biopsies, and not only the new ones, transplant biopsy should be stained by C4D. So what is the criteria that we work with for antibody-mediated rejection? There is 3 cardinal features which has to be met before we say this is a patient which is rejecting, have antibody-mediated rejection. 3 cardinal features. The first one is that we need to have morphological evidence of acute tissue injury, meaning that you need some evidence of tissue injury in the biopsy. This can range from acute tubular injury, from just an acute tubular injury, usually with a minimal inflammation, to having neutrophils and or mononuclear cells meaning lymphocytes and plasma cells, in peritubular capillaries and or glomeruli and or capillary thrombosis. So any entity of this is enough to grade it into type 2. And this is what we call now microvascular injury. And this is what I want you to focus on. So what is this story? What we're saying is, if I found only in the biopsy just neutrophils, like here, this is the tubule, you can see the amount of neutrophils within the peritubular capillary. This here again are neutrophils in the glomerular loop. And this is thrombi. This pink one here, this is the glomerulus, this is a thrombus. Again, tubules. These are necrotic tubules. This is badly injured tubules, and you can see that you have glomerulitis here by neutrophils and by lymphocytes. This is an and an or. It means it's not must to have the neutrophils. Usually you have them, but it's not a must. You can see the neutrophils here again and by EM. Again, peritubular capillaritis neutrophils here and within the glomerulus. This is a dilate, this is a rejecting kidney. You have a lot of edema and a lot of inflammatory cells. You can hardly see the tubules, and you can see a dilate peritubular capillary full of neutrophils. There is around 10 of them in here. And you can see that this is a high power of the previous photo, and this is thrombosis. This is the glomerulus, and this is all this endothelial swelling, necrosis, and abnormal necrosis, and these are the tubules inside the glomerulus. So studies showed that microvascular injury is actually a very important factor or determinant factor of antibody-mediated injury. It means that what happens is that antibodies hits the microvasculature first, and the kidney responds by what we call MI or microvascular injury. And hence, the score was added to our existing scoring system of the peritubular capillaritis, the amount of inflammatory cells we see within the peritubular capillaries, and whether it's 1, if only 3 to 4, 2, 5 to 10, and 3 is more than 10. Means that if I have in the peritubular capillaries less than 3 cells, I have to accept this as the normal circulation. This is a bit of an old transplant biopsy. This comes from 1.5 years post-transplant. Can you see the amount of cells in the peritubular capillaries? Everywhere. And even there are neutrophils. So this is a microvascular injury. I showed it's even more apparent in the trichrome. So here they are. This is plasma cells and lymphocytes. Here, look at this peritubular capillaries. You see the amount of inflammation in it. And this was with the C4D. This patient was C4D positive. You can see the peritubular capillary here, and you can see the inflammatory cells. And this is how C4D draws out the inflammatory cells. This is the immunohistochemistry. This is tubules, and this is the C4D positive. Then the third type is macrovascular, is when we get to the large vessels. Exactly. Not any vascular inflammation is considered to be under antibody mediated. Okay? So vasculitis or enthemal arthritis or vascular rejection per se does not equal antibody mediated rejection. At that time, until now, this is the solid criteria we have, is that, or according to all evidence-based, only type 3 I should consider to be either antibody-mediated or T-cell mediated. But it could be antibody-mediated. Meaning that V1 and V2 are T-cell mediated. So only the one with the fibrinoid necrosis. And if I have other features, then I'm going to classify it as antibody-mediated. However, now there is the most recent studies, and in the last update, there is a group who came up with evidence that actually this enthemal arthritis could also be linked to antibody-mediated activity. We basically measured the NK cells, cellular cells, which are present in the process. However, this is one study from one group. We need more evidence. Why am I insisting on these points? I'm insisting on these points because of the treatment of the patients. Because this makes a hell of a difference in the treatment of the patients and in the treatment regimen. So till now, what we can really rely on and what we know is that this is only the region that I should consider under antibody mixing. If I have this, I still should consider that the patient has T-cell mediated rejection. The last factor, and it's an important factor, is the presence of circulating antibodies, whether DSA or anti-HLA antigens. So these are the criteria. I should add to it draft dysfunction. Number 4 is draft dysfunction. That you have clinical evidence as well that the patient is not well. If I have 3 out of 4 criteria, this is just suspicious for ABMR. It does not equal antibody-mediated rejection. And because C4D is one of the criteria we should consider antibody-mediated rejection in it, it was important to define what do we really mean by C4D positive. So you need to look at C4D when you have intact endothelial cell layer, meaning don't have a graft which is infarcted or tubular necrosis, severe tubular necrosis, and expect that your C4D should be accurate. And then you get a report that C4D is negative, and hey, the patient is C4D negative, this probably was not antibody-mediated. No. If you have tissue necrosis, you have no endothelial cells to catch the antibodies or the complement. So this C4D result is totally unreliable. You also do not look at it in the scarred areas because the peritubular capillaries they get reduced by the fibrosis, so you might not see it. Okay? The positive part is that we evaluate C4D either in cortex or medulla. So if the peritubular capillaries in the medulla are positive, this means that the patient is C4D positive. But we have a threshold for positivity. We need more than 10% of the peritubular capillaries of the surface area of the PTC involved. Less than that, I would consider it indeterminate. We don't know what to do with it. If it's immunofluorescence, it has to be strong and linear staining, circumferential. And personally, I also request the same thing in immunohistochemistry. And there were also some studies which showed I need a continuous staining in immunohistochemistry, not an interrupted one, even if it's not strong. But I like to see it circumferential. I like to see it all through the peritubular capillary line, because this interrupted staining of C4D is not actually within the context of C4D positivity. As I said, either cortex or medulla, no scarred or necrotic areas, that's the minimum threshold level we have to do with. The other important point is C4D positivity is only in peritubular capillaries, not glomeruli. So if the glomeruli are positive, then that doesn't mean that the patient is C4D positive. Even if it has transplant glomerulopathy, and as I said, I like it to be circumferential and a continuous staining, not really interrupted to be positive. You can perform it either by immunofluorescence or immunohistochemistry. It has the same advantages and disadvantages of using immunofluorescence and peroxidase anywhere. Fluorescence gives you no background and strong staining and internal staining control, but it needs a special equipped place to do fluorescence. Immunohistochemistry, you have more tissue available, it's on the same core you take. It has a superior morphology, so you're sure you're looking at the peritubular capillaries. However, it can give you weaker staining. Because this was very important, we needed to define the staining patterns and know what's the difference between using immunofluorescence and immunohistochemistry. This is a test. And when you come to classify the diagnosis, or when the diagnosis would depend on the use of a test, which has a lot of fallacies, then you need to standardize the procedure and the interpretation as much as possible. So what we figured out is that actually by immunofluorescence it's much more sensitive than immunohistochemistry. So IHC is only one grade less sensitive than IF, and this is something which has to be known during the interpretation. So when you score the C4D, or what's considered positive or negative, has to depend on the technique used. What is negative by both is negative. However, and what is positive by both is positive. What's more than 50% is positive. However, we have these, the focal ones, the ones with the minimal C4D staining, less than 10%. This usually, if it's by immunofluorescence, we will consider it negative. But if it shows up with the immunohistochemistry, we don't know. We still don't know what's the significance of this. And same here. Focal 10 to 50%. We don't know what is it if it's in the immunofluorescence, but this is positive in immunohistochemistry. So if we're using immunohistochemistry as we are using it here in Egypt, C4D2 and C4D3 is considered positive. So even by immunohistochemistry, if I scored it less than 50%, I know this is less sensitive, so this is a positive C4D stain. So as I said, we added these criteria to the Banff 97 classification. So this is acute rejection, T-cell mediated rejection and acute antibody mediated rejection, as was as till now. Then we have the problem of chronic rejection and the chronic allograft nephropathy. By time, or at that time, or we don't know what happened, but what happened is that chronic allograft nephropathy became a specific disease rather than another term for non-specific parenchymal scarring. This is what CAN changed into, that it became a disease. And by time, no two people could define the term CAN, and no histopathology consensus on what we call chronic allograft nephropathy. This term was a huge error. And let me tell you why. What goes under chronic allograft nephropathy? Arteriosclerosis, arteriolar hyalinosis, interstitial fibrosis, glomerular sclerosis, transplant glomerulopathy, tubular atrophy, donor's disease. Is this chronic rejection? Is this CNI toxicity? Is it viral? Is it obstruction? Is it recurrent glomerulonephritis? We know that each one of these entities, which will present as chronic changes in the biopsy, have a different pathogenesis behind it, and accordingly dictates different treatment to the patient. So by using the term chronic allograft nephropathy, what does it signify? What does it say? Which one of these does it tell you? And the challenge was, can you diagnose CAN? Do you know a disease called chronic native nephropathy? Do we have anything like this in the kidney? There is nothing. Yes, we don't have something like this. So why do we accept such a term, and why don't we still use it? It's a term which shouldn't exist. So thankfully, by 2007, they realized their mistake, and the term chronic allograft nephropathy disappeared. We don't use it anymore, and it was replaced by two entities. The first one is IFTA. And IFTA stands for interstitial fibrosis and tubular atrophy. And the second one came with the discovery that we don't only see C4D in recent biopsies, we also see it in old biopsies, we also see it within chronic changes. So we have an entity which is known as chronic antibody mediated rejection or chronic humoral rejection. I will define the term here just for the purpose of discussing what we have now. 15 minutes. 15. The main problem is, and CAN used to sum both these categories: interstitial fibrosis, tubular atrophy, and chronic antibody rejection. So IFTA, or what we use now for interstitial fibrosis and tubular atrophy, is basically not an inherently progressive thing unless we have a new injury. So it's an evaluation of the amount of interstitial fibrosis and tubular atrophy which is present in the graft. Whatever the reason could be. It could be a legacy of rejection, it could be an inherited donor disease, whatever, drugs, infections. What we do is that we try to specify the cause of the interstitial fibrosis and tubular atrophy. And if we failed, then we are going to use the term NOS or non-otherwise specified. The target is that you know that your patient has an established chronic injury within the tubulointerstitium. But then comes the other entity, which is chronic active rejection. This includes chronic transplant glomerulopathy, peritubular basement membrane multilayering, sclerosing or sclerosing vasculopathy, plus or minus the C4D and clinically the presence of donor-specific antibodies. So these are the triad of chronic active rejection, plus if. So the basement membrane duplication, chronic transplant glomerulopathy. Chronic transplant glomerulopathy is a term which was applied to the glomeruli because the basement membrane of the glomeruli undergoes diffuse, thickening, and duplication. What is it? It's an endothelial injury, and it can be detected very early post-transplant by electron microscopy. So we're even dropping the term chronic and just saying transplant glomeruli. It can be preceded by glomerulitis. Usually you get inflammation in the glomeruli first, maybe as a form of rejection, then this inflammation develops into this basement membrane thickening. This was an entity which was first described as part of the chronic antibody-mediated rejection category. However, this is not true because we have 20 and up to 50% of the cases from 20 to 50 C4D positive. This is a huge gap. So not all transplant glomerulopathy is chronic antibody-mediated rejection. Around 60% have associated chronic vascular changes with them. What happens is that the patient has slow rise in the proteinuria. They have no specific therapy for the inactive forms, and it has a poor prognosis. And this is CTG or chronic transplant glomerulopathy. Is it like the membranoproliferative glomerulonephritis? Yes. Is it difficult sometimes to differentiate between it and between other entities? Yes. So this is what you have. This is the duplication of the basement membrane. So when we see this, we think of transplant glomerulopathy. Again, this is the glomerulus. You have the diffusely duplicated basement membrane. One here and one there. Another one, I think it's even more clear with the blue. This is the basement membrane. That's another one. So you have what we call a transappearance of the basement membranes, and this is by the EM. This is first the basement membrane, and this is the second one which is formed. Yes. This is peritubular capillary basement membrane multi-layering. This is a finding only by electron microscopy, and you get multi-layering of the basement membranes of the peritubular capillary, again a chronic sign of rejection. Sclerosing transplant vasculopathy. Now this is related to the arteries. This is a chronic change. Happens late, usually after transplant. This is induced usually by entiment arthritis. So these are the patients who get entiment arthritis and vascular rejection and are not treated adequately. You do not get, if you don't do a follow-up biopsy following the treatment of acute rejection, you don't know whether the rejection resolved or not. And these are the patients who usually develop later this type of chronic rejection. Again, only around 30% of these patients are C4D positive, although this has been described in the beginning as antibody-mediated rejection. Now this is a biopsy from a patient 52 days post-transplant, and you can see the antibody arthritis very nicely. Yes, you can have the endothelium and a lot of lymphocytes. This is his biopsy 420 days post-transplant, and you can see that all of this has been replaced by fibrosis. All this thickness, this is the normal, and this is the thickness. Okay? ongoing stage in between. Meaning, you can get both the fibrosis and the inflammation. Like what you see in this artery. This is, just for you to orient, this is the wall of the artery. Okay? And all of this is inflammatory and intermediate inflammation. Up till here. Can you see the lymphocytes here? Among the fibrosis, and this is what we call sclerosing vasculopathy. This is the one which is going to end by fibrosis. So this is the second and very important misconception, that you go with acute and chronic rejection are separate time-dependent entities, which are not. Chronic refers to changes which is induced in the graft or the response to the kidney, basically vascular remodeling, as the case of the duplication of the basement membrane. It's not a time-dependent entity. This is what we say acute, right? If you consider this is time, this is 0 hour post-transplant, you have all these early acute changes. But look, the acute changes can go when? You get very surprised from a post-transplant biopsy, 5 years post-transplant, where it says active rejection. Why are you surprised? Who said that a 5-year or 7-year post-transplant we could not get active changes? Much lesser percentage, but it's not unexpected or impossible. On the other hand, you have the other side of the story, which is the chronic, the sclerosing and the sclerosed part. But see, when does it start? You can have chronic changes as early as 2 weeks post-transplant. What about this orange triangle, which is in between? You have a chronic active stage. You have an overlap between the inflammatory process and the chronic changes. And this is where we say that we have a chronic active rejection. This is where processes like transplant glomerulopathy, like sclerosing vasculopathy lies here. So chronic active stages means that you still need to treat your patient. It doesn't mean that the patient is in chronic rejection. So by 2008, we have a new classification which we work with till now, which is the Banff 2007 classification, which incorporated all the following, including the new entity that we can have C4D deposition without or with minimal histological changes. So back to the categories. We have the normal, we have the antibody-mediated changes. Now it's called antibody-mediated changes. Why? Because we have C4D deposition without morphological evidence of active rejection. We have acute antibody-mediated rejection, which is two types, and we have chronic active antibody-mediated rejection, which will include transplant glomerulopathy, which will include arteriosclerosis, IFTA, and so on, if they are C4D positive, and we have DSA. We have category 3 as is, and we have T-cell mediated rejection, again acute and chronic active. So we can have chronic active, again T-cell sclerosing vasculopathy, which is T-cell mediated, and probably could be as well transplant glomerulopathy. And we have number 5, which is the IFTA, which if we don't know the cause of the interstitial fibrosis and tubular atrophy. And we have number 6, other changes not considered to be due to rejection. That means viral infection, okay, and any other thing. Because a native kidney, transplant kidney is after all a kidney. So anything can happen to it like a normal kidney, including all the acute and chronic changes. So this is what we work with. But what we work with have a lot of problems. And mainly is that the classification of the antibody-mediated rejection has no evidence base. We don't know whether type 3 does worse than type 2, or that type 1 would do better than type 2, and so on. We don't have a mixed rejection category, and we have a problem with the scoring of the interstitial infiltration category 3 borderline is insufficient, and so on. So we have a lot of problems with this classification, and this is what we've been working on the last 4 to 5 years in the Banff 09 treatment report. If we go very quickly now for the sake of time, I just want to tell you that before we used to focus only on the scoring of the interstitial inflammation in relation to rejection. So we used to ignore any area with fibrosis, subcapsular, exactly. We don't do this anymore because this what changes into fibrosis. So what we work on now is what we call a total eye score. We score everything. We score the subcapsular, we score the nodular, the perivascular infiltrates, and the fibrosed area, which we call eye IFTA. So we don't use only the acute eye score, we actually use both, or if your pathologist scores it, I don't. We try to work on the relationship of transplant glomerulopathy on C4C and on the prognostic factors we have for these features in antibody-mediated rejection. Most importantly is the entity of C4D negative antibody-mediated rejection. And this again something I want to stress on. Bear in mind this entity came with phenotyping of the late allograft loss. So of the conclusions of the 2011 report, which we all agree upon, is that we have 2 phenotypes for this type of rejection. Phenotype 1 is the one which was developed in the pre-sensitized patient early post-transplant and is C4D positive. So do not expect to have your patient rejecting antibody-mediated early post-transplant because and say that this is ABMR and his C4D is negative. If you're sure the C4D is performed properly. So please forget the C4D negative antibody-mediated rejection entity early post-transplant. This is an entity for the late post-transplant for patients who develop de novo antibodies, okay, late post-transplant, mostly in relation to non-compliance, ودول هم دول اللي بيبقوا usually C4D negative. So this is how we look at rejection. You have acute, active, antibody-mediated cell-mediated, chronic active, antibody cell-mediated, and chronic antibody cell-mediated. I just want to make sure that you understand these terms because we have a lot of debate on these terms and they are not adequately defined. So what shall we do in relation to how we read the biopsy and how we interpret the findings of the biopsy? First, know that morphological features are dependent on the time point of the course of the disease. So this doesn't mean that this is what we're going to have later on. Second very important point is that the dynamics, especially in antibody-mediated rejection, show significant individual variability. Not all patients respond the same. So we have to agree to use correct terminology first. Antibody-mediated does not equal vascular rejection. So when you get a report of vascular rejection, don't rush to treat your patient with plasmapheresis. Check first which category he is, look at his C4D, whether it's positive or not, try to do donor-specific antibodies first, and then decide whether you're going to give ATG or perform anything else. These two entities are not the same. This is a mechanism and this is anatomy. We're saying that the vessels are rejected depending on the anatomy. Second is try to look at the rejection process according to the anatomical compartments. Count on the histological lesions, which ones you have which are rejecting. And this what should dictate your therapy and the prognosis of your patient later on. You have the rejection on arterial basis, and what you have in it, thrombosis, necrosis, just antimal arteritis, or is it a chronic active rejection? If you have it only on the glomerular basis, it's a microvascular injury, and it makes a difference which form of microvascular injury are you having, or is it in the tubulointerstitial compartment? Then decide which type of mechanism is behind this findings and findings. This is the antibody-mediated response at one end. And you have at the other end T-cell mediated response. But this is where most of our patients actually lie. This is where your patients are. And always remember that even if you have a C4D positivity and positive donor-specific antibodies, this could be dominant, so you could be here, or more commonly, co-dominant, so you are here. So don't just look at C4D positive or at positive DSA and panic, and just go that this is ABMR. Remember, patients have mixed rejections, and that you need these 4 criteria to balance whether you have really ABMR or an antibody-mediated response, which you can control by controlling the T-cell mediated response. This could be co-dominant. Our immune system doesn't work arbitrarily. So if you have an antibody-mediated arm within the rejection process, sometimes you can control it easier when you control the dominant feature, which could be the T-cell mediated. And remember that C4D positivity would cover all of these circuits, and only pure antibody-mediated rejection is this small percentage here. So my message is you really need to know how to use with the C4D correlated to what you are finding. This is a subclassifier, a diagnostic addition. It is not to classify patients into acute ABMR or chronic ABMR. I'll give you, I think we have 2 more minutes just for the cases to show you what we're talking about. So this is a patient, these are real life cases. 31-year-old male with end-stage renal disease due to focal segmental glomerulosclerosis. He had his second renal transplantation instead of 2003. First, you think this patient should have undergone a second renal transplant? And he is originally allogeneic. Renal function after transplantation improved rapidly under ATG induction. So he already received induction since this was his second transplant. However, he had subsequent rise of the serum creatinine to 6 milligrams and evidence of proteinuria 3+. So they had diagnostic graft biopsy was performed on day 10 post-transplantation. What are you expecting to see? Quickly, recurrence. ممكن حاجة ثانية غير recurrence أو حاجة مع recurrence because of the proteinuria. Okay, so this is the patient we saw. This is the same photo. Can you see the inflammation? Can you see the tubulitis? So do we all agree that he has a T-cell mediated rejection based on this area? Good. Or we all agree that this, at least for now, is type 1? Okay, good. So this is 1A. What do you think of this artery? This is the artery. Why not? No, this is only the wall. This is swelling endothelium. You have all of these lymphocytes. So this is erythemal arthritis. So this will move us from type 1 to type 2. So now we are in type 2. And what do you think of this C4D? This is positive. What would you diagnose this patient? Any other opinions? Would you consider it antibody-mediated rejection? Would you just simply label this patient antibody-mediated rejection because he has vascular rejection and he's C4D positive? Okay, I'm glad, because a lot do this. Yes, no. This is a mixed rejection. You have category 4 rejection, TCL mediated, both based on the findings we have, and we have a category 2 rejection based on the C4D positivity, and we know that this is a sensitized patient. And you could have recurrence as well. This is not a big deal. The patient had proteinuria because he had a TMA, he had a thrombotic microangiopathy as part of the rejection process. The second case is a 42-year-old female who underwent transplantation early 2005. Operation was uneventful, negative cross-match, no induction therapy, original disease unknown, a typical patient. Phase 3 oliguric, sudden rise of serum creatinine up to 3 mg/cent. She was on cyclo, MMF, and steroids. Day 3 oliguric sudden rise of keratosis.
So what is my
As in she is a thrombotic microangiopathy. True. But did you say thrombotic microangiopathy as thyroid foreign toxicity? Okay, I'll agree. You see the supernecrosis. This is quite an aggressive CMA. You see the glomerulus. You have a lot of glomerulitis as well. We have neutrophils. Okay? And you will see a lot of peritubular capillaritis. And yes, of course, you could see an eye induced. This is the trichosis and the steven thrombosis and the hilar arterioles. Yes, quite an extensive CMA. But you have also glomerulitis here. C4G positive. So what would classify this patient? Mixed why? Why mixed? What evidence you have here? We have a T-cell mediated rejection.
position of CD4D?
That's an antibody mediated response.
Vascular.
So when we get thrombotic microangiopathy, our problem is that whether this is drug-induced or antibody-mediated rejection. This is antibody-mediated rejection. Now, thrombotic microangiopathy is a descriptive term. It's not a disease and does not equal hemolytic uremic syndrome. Okay, do we agree on this?
Yeah.
Good. And when we agree this is a microangiopathy, meaning this is a microvascular injury which can produce glomerulitis, thrombosis, endothelial cell swelling, and even duplication of the glomerular basement membrane, whether induced by calcineurin inhibitors or induced by antibodies. You don't get any other finding in the biopsy except the TMA. You don't need any cells to make this diagnosis. There is no cellular infiltrate. Look here. Look at the tubular infestation and the tubules. You only have tubular injury, extensive tubular injury. You have no inflammation, and the arteries of this patient were very fine. Okay? So, but her C4D turned to be positive. So this is a pure antibody-mediated rejection, considering the fact that her DSA was positive. So we need a slide to classify rejection according to morphological changes and use C4D as a diagnostic qualifier. This was supposed to be a quiz. So, transplant glomerulopathy, does it generally mark antibody-mediated rejection? What's the answer, yes or no? If you have a patient with transplant glomerulopathy, would you say that this is chronic antibody-mediated rejection? No, thank you. Because another point I want you to remember, since we are in Egypt, and hepatitis C, we produce similar glomerulopathy, similar changes like transplant glomerulopathy. That's number one. Number two is that those patients which can have a TME subclinical, they will develop chronically into the same thing. That's another quiz. We have a case of delayed graft function with marked acute tubular injury. What do you think? Is this histological change sufficient to make a diagnosis of category 2 type 1, ATM-like? We said that the category 2, which is antibody-mediated rejection, type 1, which is the acute tubular injury. Is it enough? No. So what else do we need? Yes, this patient is C4D negative, because only a minority of cases with acute tubular injury turn to be C4D positive and turn to be part of the antibody-mediated injuries. Don't read the classification and panic, and whenever time we have an acute tubular injury, consider it antibody-mediated rejection. Classification schemes come and go, even Banff. However, the morphological patterns of disease are the ones which remain the same. Thank you.
شكرا وسام دايما بتستعين بالعرض الشيق يعني